Which medication should the paramedic consider early according to protocol? It's two-step.
Okay.
A dialysis patient has missed 2 treatments. The patient is weak, nauseated, and confused, so he's sick and unstable.
Nice.
BP is 90 over 50, 2. His pulse is 38, and his respiratory rate is 22. SpO2 of 96%. The ECG shows a wide complex bradycardic rhythm with peaked T waves.
All right. So what are they describing here?
Hyperkalemia.
Okay. What's our treatment for hyperkalemia?
Initials mean calcium chloride.
Okay. Calcium chloride or calcium gluconate. Which one is more potent?
Calcium chloride.
Calcium chloride. Okay. And we already see that in the answer choice. We can just go ahead and pick it. But what are the other treatments for hyperkalemia? So what are all the treatments?
So it's A, B, C, D, I, K, and that
A, B, C,
is
D's, and then IK. Okay. What's the A?
uh so that's albuterol.
Nice. How does the albuterol work in this situation?
Um is that this the to bring something back into the cell, right? Or
Uh-huh.
vasodilation? Or
Not that
bronchodilation.
part. Okay, so
Bronchodilation.
here's what's happening. These little dots, they're going to represent potassium. So we've got too much potassium inside the blood right now. Originally, the potassium is supposed to, well, the potassium starts off inside the cell at rest, but now, for whatever reason, like let's put a membrane on the outside here. Well, this membrane has gotten damaged.
Mhm.
Okay. So the cell membrane starts to get damaged. Now we've got holes in our borders. So what's happening is some of this potassium is now leaking out and it's getting into the bloodstream. We need it to get back into the cell out of the bloodstream. And how do we do that? Well, we're going to activate the sodium potassium pump. Okay. So this little rectangle here is the sodium potassium pump. Its job is to send sodium.
Back
So the
in.
sodium starts off on the outside and makes its way on the inside. And then that sodium has to be pumped out through the pump. So sodium, so it's called sodium potassium because sodium goes out and then potassium goes in. Okay. 3
Okay.
sodiums go out, 2 potassiums go in. So here, let's do 3 sodium out and then 2 potassium in. That's the job of the pump. We have 2 ways that we can activate the pump. One of them is on the pump, there's what's called a beta 2 receptor. So we can use some kind of beta 2 drug like
Albuterol.
albuterol to activate the beta 2 receptor, the beta 2 receptor here of the
Mhm.
pump that turns the pump on, and now it pumps the potassium back into the cell.
Okay.
Another way to activate the sodium potassium pump is with insulin. So another way to do it is through insulin. Same thing. Turns on the pump, and now it pumps the potassium back into the cell.
Okay.
Okay. So the albuterol and the insulin both turn on the pump. What else do we use?
Bicarb.
What's the okay? How does that work?
It like negates the acid buildup.
Yes. So what's going to happen is we're going to get more hydrogen inside the cell. And whenever you have too much hydrogen, that's acid. So to counteract all this acid here, we're going to use the bicarb. Okay. The C, of course, is the calcium. How does
Calcium.
that work?
Stabilize the cell membrane.
Okay. The calcium is what's going to stabilize the membrane. We're going to kind of clean this up and secure the border again. Okay, that's the calcium. And then what's the D's?
Diuretics,
Okay.
dextrose, and dialysis.
Okay, nice. Diuretics. Diuretics, dextrose, dialysis. Okay. And how does the diuretic work?
So does it filter out?
Well, so that's actually dialysis. Dialysis is going to filter it through a machine. It's going to filter the excess potassium from the blood. The diuretics is going to cause you to just pee off
Urination?
the excess
Yeah.
potassium. And then the K For K-exolate, that's going to be
K-exolate.
given at the hospital. That's going to
So
cause
poop
you
it
to
out.
poop off the excess potassium.
Okay.
And then why do we give the dextrose?
Because we need to give insulin
Nice.
for the sodium potassium pump. So you have to give insulin. So you give dextrose to stabilize the blood sugar.
Yes, exactly. Because insulin is going to drop the blood sugar, so we got to bring it back up with some dextrose. Nice, very good. Does it help to have like this picture of hyperkalemia versus just the protocol say to do it?
Yeah.
Okay. Was this something that you knew well before me?
No.
Okay. And I really want you guys to always understand the how and the why. So insulin, where does it come from? Who
The
makes it?
pancreas is the
Pancreas.
beta cells. The
Nice.
beta.
It's the pancreatic beta cells of the islets of Langerhans. Okay. The islets of Langerhans make other hormones as well. What are they, and what are the cells that make them?
So glucagon is the alpha.
Okay.
And the delta is, okay, hold on. I had it on my head like a second ago.
That's okay. Hey, that's okay. But in that situation, you at least know like two of the three. So the alpha cells make glucagon, the beta cells make the insulin, and the delta cells make somatostatin.
Somatostatin.
Somatostatin. Okay. It's like the emergency brakes. It's like the kill switch for the shut off valve for the body. That and GABA. Okay, let's do another one.
Which treatments may be appropriate according to protocol? Select the two correct answers. Okay, so it's a two-part. A patient has suspected hyperkalemia with wide QRS complexes.
Okay. So we got
Peak T wave.
hyperkalemia. Give me two treatments for hyperkalemia from this list. Let's start at the bottom.
So it's not going to be adenosine. You wouldn't give adenosine for a wide complex.
Nice.
Aspirin doesn't say anything about chest pain.
Okay.
Nitro, no, he's got poor perfusion, so he's likely hypotensive to start with.
Like it. Nice.
Sodium bicarb and calcium are both part of the ABCDIK. D's
Nice.
IK.
ABCDs IK. Great. Okay. But you got to know the ABCDs IK to be able to kind of pick the list. But otherwise, even if you didn't know that, we were just able to eliminate down to the answers. All right. This is a matching. When we have these kind of situations, what we want to do is start with the bigger side. And
Okay.
just match each one of these. Now, in this case, because you're going to use all of these, it doesn't matter if you start from the bottom, but if you want to start from the bottom, we can. Let's start from the bottom since that's what we're doing normally. Let's just start from the bottom. Bradycardia with complete AV dissociation matches which one of these?
So that is a third degree, so complete heart block.
Okay.
Hypotension and bradycardia with inferior ST elevation is 2,3 AVF, so we're looking at 1. P waves and QRS complexes marching independently, that's a complete heart block. Wide QRS with peaked T waves after missed dialysis is 3. ST elevation in V1 through V4 is going to be anterior. And ST elevation in 2,3 AVF is going to be inferior.
Okay,
So 1.
good. All right. Now, if we have, okay, let's do it a different way. Let's say they tell you you have elevation in leads 2,3 AVF. What's the blood vessel?
RCA.
Primarily the right coronary artery. If we have elevation in V1 through V4, what's the blood vessel?
Left anterior descending.
Nice. That's LAD. Okay. Okay. If we have elevation in 1 AVL V5 V6, what's the blood vessel?
Circumflex.
1
Is it
AVL V5
circumflex?
V6. That's going to be lateral, so that's going to be the circumflex artery. Okay. Nice. Okay. Okay. Let's do another
one. What should the paramedic do next according to typical protocols? It's a 2-step. A 43-year-old patient has sudden palpitations. The ECG shows a regular, narrow, complex tach at 188. Patient is alert. BP is 126/78, and vagal maneuvers are unsuccessful.
Okay.
Okay, so
let's summarize this. Let's give this a name. What kind of situation is this? Is this stable or unstable?
Stable.
Okay, because his blood. Okay, he's alert.
They're still perfusing okay, and they're alert.
And blood pressure is still okay right now. What? Okay, so we're going to call this stable. Now, what would make it unstable?
Altered mental status, hypotension. Okay.
Chest pain, altered mental status, shortness of breath, hypotension. So catch.
Okay,
he does have palpitations, but he doesn't really have anything else. Okay, so we're going to say he's stable. And then is he having symptoms or no symptoms?
Symptoms.
He's definitely having symptoms. Actually, let's flop these. Let's call this one symptomatic. And then stable. And is it tachycardia or bradycardia?
Tachycardia.
Okay, so what's our treatment for symptomatic stable tachycardia?
Since vagal maneuvers are not successful, then it would be adenosine.
Okay, so we typically would go vagal, then adenosine, then if that doesn't work, we do another adenosine, and then wait, what do you call it?
Yeah, I stopped myself. It would be a synchronized cardioversion.
Yeah, then cardioversion. Okay, now what if they're unstable though?
Yeah, it would be an immediate synchronized cardioversion.
Yeah, if they're unstable, we go straight to synchronized cardioversion. Okay, and then we try to get IV access if we can, and pre-medicate them to go ahead and sedate them before we light them up with this electricity. What would be our drug of choice to use for the procedural sedation?
Be Versed.
Okay, so Versed, also known as
midazolam,
which is a
benzo.
Nice. Okay, how does it work? That's okay. So a benzo increases the frequency of chloride channel openings. Basically, so here's a cell. Remember, everything comes down to the cell. Here's a cell. On a cell, there's a chloride channel. I mean, there are lots of channels: sodium channels, potassium channels, chloride channels, calcium channel. But in this case, we're talking about the chloride channel. And what we're doing is we're saying we open the channel faster. So when you open a chloride channel, what it does is it takes chloride from the outside of the cell and it now sends it into the cell. But remember, chloride has a negative charge. So when I open the door and I let a lot of chloride rush in, it makes the inside of the cell very negative, and that's what calms down that stops the depolarization, because depolarization is where it's too positive and all kind of craziness is happening. We're going to calm that down by putting a bunch of negative inside, and then that slows down the heart rate. Okay, so benzos work by increasing the frequency of chloride channel openings, and on the chloride channel there's something called a GABA receptor. So benzos and barbiturates both activate the GABA receptor on the chloride channel. Okay? Benzos and barbiturates both activate the GABA receptor on the chloride channel.
Okay.
And that allows chloride to go into the cell with a negative charge, and it calms down, it slows everything down. The difference in benzos versus barbiturates is benzos increase the frequency of the channel. Barbiturates increase the duration. So I like to say barbiturate. So barbiturates like phenobarbital, secobarbital, barbiturates increase the duration of the channel opening. Both of them still work on the channel. One of them just makes the door open faster. That's benzos. Barbiturates just keep the door open longer. So that's duration. How long it's open versus how fast it opens. They both deal with it opening. Make sense?
Yeah.
Can you teach that back to me?
So the benzo increases the frequency of the opening of the channel to release chloride
Which
into the
channel?
cell.
Which channel?
The GABA or the
No,
chloride channel
it's going to be the chloride channel, and attached to the chloride channel is the
is GABA.
the GABA receptor. So let me just let me clean that up. So here, let me just get some space so we can do that again. Here's a cell. On the cell, there's a chloride channel. That's how chloride is able to get in or out. Okay, because remember, all this chloride is on the outside, but we need it to get inside, and the way it has to get inside is it has to go through the channel. We either have to open the door, or we got to keep the door open longer, but either way it's got to get open. Now on the chloride channel is a GABA receptor. So this is GABA receptor, and then what attaches to the GABA receptor is GABA. What is GABA? It's an inhibitory neurotransmitter. So it inhibits things. It's a neurotransmitter that slows things down. We also have neurotransmitters that speed things up. That's going to be things like glutamine. In this case, GABA, it calms things down. Because they're having a seizure, things are like amped up in the brain. We need to calm things down. This is like the other emergency brake of the body. Okay? So we have two ways that we can activate this GABA receptor on this chloride channel. One of them is with a benzo. The other is with a barbiturate.
Barbiturate.
They both activate the same thing. It's just they do it in different ways. The benzos increase the frequency of the channel opening, and the barbiturates increase the duration of the channel opening. Okay?
Yeah.
Does that make a little more sense?
Yeah.
Try it again.
Okay. So the benzo increases the frequency of the calcium channel opening.
Not calcium, chloride.
The chloride channel opening. And the barbiturate increases the duration of the channel opening.
Yes.
So keeping
one
it
of them just
open.
makes the door open faster. The other just, once it's open, it keeps it open longer. Either way, the net result is still the same. Chloride, because the door, once it's open, chloride can now go in. So the chloride now goes into the cell, and it makes the cell very negative. Okay?
Yeah.
Does that make sense?
I think so.
Okay. I mean, you may not even get a question like that, but just in case, I want you to kind of understand how the drugs work. Okay, now let's go back to this question. So this question was, we have a symptomatic stable tachycardia. We already tried a vagal maneuver. Now what's next?
It's me adenosine. It's going to be 6
now
milligrams.
It's going to be adenosine. So that's going to be 6 milligrams adenosine. How do we do it?
Three-way stopcock.
Three-way stopcock and push. Rapid push with a flush. Okay. So about 20 ml flush is what you want to use, because we got to really push this all the way and get it to the heart. Why do we have to give it so rapidly?
Is a very short half-life.
Yep. So, and what is the half-life of adenosine?
Is it like 6 seconds?
Yeah, like 3 to 5 seconds. It's really fast. How does adenosine work? So it decreases AV nodal
conduction. Okay, yeah.
That's just a fancy way of saying slows down the heart rate.
AV node.
There are 3 ways we do that. 3 ways we decrease AV nodal conduction or slow down heart rate. And these are our ABCs. The A is adenosine.
Beta blocker and calcium channel blocker.
Yes. Beta blocker, calcium channel blocker. Okay. Beta blockers. How do we recognize beta blockers?
The OLALs.
OLALs, okay. Or the LALs. How do we recognize calcium channel blockers?
Well, there's 2 of them. The 2 classes. So there's the dihydropyridines and the non-dihydropyridines. So that is going to be the dapines and then
non-di.
that's going to be your cardizem, diltiazem, and verapamil.
Okay, I'm sorry. I was talking over you. Say it again so I know which is which.
So the dihydropyridines are going to dilate the vessels. That's going to be your like your amlodipine, nicardipine, um,
Nifedipine, yeah.
the
Okay.
dipines. And then
Dipines,
the
yes.
the non-dihydropyridines are going to be like your cardizem, diltiazem, verapamil. They like work on
Nice.
the heart themselves.
Very good. I love it.
I've been
I
listening to the
love this.
audio drills. Like, I mean, even laying down on the couch, I have you in my ear. Like,
Oh, I love it. No, I love what I'm hearing. This is amazing. Okay, keep going.
but then I still
So
feel
this
like I'm not ready for these.
Well, I mean, like I said, you're probably way more prepared than you think you are. The way
Yeah.
you're answering these questions, I mean, think about it. Like, did you know this same stuff for your last
No.
attempt? But you're
No.
just rattling it off with no notes or anything.
Yeah.
I mean, you've definitely put in the work. So I think you're in great shape. Let's keep going.